fall quarterly conversations in global health. And I'm going to start off by introducing Kaylin Chan, the program intern for Unhoused, and she's just going to say a couple things about the Global Forum programming.
Thank you, Suhani. Hi, everyone. Good afternoon. I hope you're all doing well. My name is Kaylin Chan, and I serve as one of the Unhoused program interns for this coming term. I'm glad to welcome you guys to one of our first Global Forum of this year, actually, the Conversations in Global Health. So for those of you who don't know, Global Forum is a program hosted by Unhoused that aims to provide spaces for people to talk about international affairs, bring cultural awareness, or generally promote a more globally oriented community. And so Global Health, of course, falls under this. And so we are glad to have back one of our favorite programs, the Conversations in Global Health. And so once again, welcome to the Fall 2025 conversation. What was it called? Health and the Unhoused. Sorry about that.
Thank you, Kaylin. So really quickly, I want to give everyone a moment to reflect and read over the land acknowledgement credited to our Intertribal Resource Center. The UCSD community holds great respect for the original people of the area where our campus is located. The university is built on unceded territory of the Kumeyaay Nation. Today, Kumeyaay people continue to maintain their political sovereignty and their cultural traditions as vital members of the San Diego community. We acknowledge them and their tremendous contributions to our region and thank them for their stewardship. It's okay. Before we begin, we wanted to highlight some other exciting global health program events and upcoming dates. So the first one is going to be Health Frontiers in Tijuana. The application deadline is Monday, December 1st at midnight. And then we have our winter quarterly conversations in global health. So if you liked this one, come back for the next one. That's going to be Where Are They Now? Global Health Alumni in Action. That's going to be Wednesday, January 21st at 3:30 in this room. We also have the Masters of Arts in Global Health. The application deadline is Tuesday, February 10th. And finally, Horizons of Global Health, the Research Symposium is going to be Wednesday, June 3rd at 3 p.m. also in this room. More information about these events will be in the upcoming Global Health Program newsletters, so if you haven't subscribed, I think we have some QR codes that you guys can scan to get on that mailing list. Additionally, for those who are in Global Health courses and getting extra credit, there will be QR codes to sign in once the event concludes. Really quickly, the events brochure, in an effort to conserve paper, please use the QR code that you guys probably scanned at the table or one of the back tables to access the event brochure. And I would like to bring up this afternoon's MC and the Global Health Program Director, Dr. Thomas Shordash, to the stage. Thank you.
Thank you, Suhani. It's a pleasure to be back here for a new academic year and our first quarterly conversation of the academic year. I'm Professor Tom Shordash, the director of the Global Health Program. And I would like to remind you that our quarterly conversations happen every quarter, except for spring when we have our Horizons of Global Health Research Symposium. And the events are made possible by the Global Health Program, by Students for Global Health, by the Center for Global Mental Health, and the Global Forum. As with all our events, the goal is to bring the global health community and the local San Diego community together to discuss important issues in this interdisciplinary field. Before we begin, we'd like to thank our co-sponsors and individuals who have made these events possible this quarter. Our sponsors for today's event, thanks to the Students for Global Health, thanks to the Global Health Program, Unhoused, the Center for Global Mental Health, and the School of Social Sciences for providing support and sponsoring this event today. We also want to give a special thanks to the Global Forum and their staff for providing the space for our event today here at the Great Hall. And finally, we'd like to thank the Events Committee led by Global Health students Suhani Pawar and Rebecca Sahagun from UC San Diego Students for Global Health, as well as our Global Health advisors, Jane Eichhorst and Brittany Wright, who all contributed to putting together this afternoon's conversation and who always make it a very smooth and satisfying event. We want to highlight our tabling organizations that are taking part in providing info to event attendees today, thanking the Students for Global Health, the Partners in Health Engage group, the Basic Needs Hub, Unhoused, and the Global Health Program for tabling with us today. We encourage all of you here to stop by their tables to find out about upcoming events and ways to get involved. I'm especially pleased by the turnout today for this quarterly conversation for which our topic is Health and the Unhoused. Our speakers today are Dr. Jeffrey Schoenberg, PhD, who is a lecturer here at UC San Diego, a medical and visual anthropologist, and an activist in the unhoused area. Dr. Patty Gonzalez Zuniga, MD, is the founder of the Wound Clinic, founder and director of the Wound Clinic, and Kate Pocock, MHS, is the Regional Director of Clinical Operations for Healthcare in Action. Each speaker will have 10 to 15 minutes to introduce themselves and make their presentation, and we'll follow this by an open discussion with questions from you all. And once again, thank you for all for coming today and supporting the Global Health Program. Do remember that those of you who are eligible for extra credit in global health courses will see a QR code at the end of the event that you can scan. So first of all, I would like to introduce Dr. Jeffrey Schoenberg, who holds a PhD from the University of California, San Francisco, and Berkeley. He is a medical and visual anthropologist and activist who works with unhoused communities and on issues of violence and suffering. Dr. Schoenberg is a recipient of the G.G. Greenhouse 2022 Community Award from the Alameda County Healthcare, from Alameda County Healthcare for the Homeless. Also recipient of the Paul Farmer Global Citizenship Award from the Society for Public Anthropology, and a Committee on Teaching Excellence Award from the School of Public Health at University of California, Berkeley. His work is on themes of violence, poverty, drugs, and visual representation. He is a lecturer here for us as part of the Global Health Program, and he also serves as academic coordinator for the Masters of Arts in Global Health here at UC San Diego. He's a fellow at the Berkeley Center for Social Medicine at UCB. Please welcome Dr. Jeff Schoenberg.
All right. Wow, it's really great to see such a great turnout, I have to say. Just give me a sec, hopefully. Oh, it is working. I'm always a little concerned. Oh, and also I'd really like to, thank everyone for being here. I'd like to thank Tom. I'd like to thank Jane for all the work that you've done to put this stuff together. And I would also like to thank our other panelists who gracefully and gratefully volunteered to participate in this, what I would say is a really important and fundamental discussion. So. I spent the summers of 2022 and spent the summers between 2022 and 2023 off and on with the community of Wood Street, the largest informal settlement of unhoused people in Oakland, California. During that time, Governor Gavin Newsom began a major push for the dismantling of or sweeping of unhoused settlements. Their dwellings stretched about 2 miles beneath one of the busiest commuter freeways in the country, on land owned by a mix of entities, and I list these in order in which they were evicted: a private railroad company, the state of California through Caltrans, the city of Oakland, and various smaller private landowners. Before the sweeps, Wood Street functioned as a fragile, but albeit somewhat of a sanctuary for its residents. For the nearly 200 people over the 8 years, it offered something rare, a place to be sedentary and generally accepted by peers. It had a core group of leaders, residents that worked tirelessly to advocate, plan events, and community organize. This community, and I don't use that word lightly, arranged and offered many things that would provide some sense of security within this space of extreme precarity. They had cookouts as well as a food pantry. They had a clothing pantry. There was access to a vast network of housed volunteers, including legal resources, events with people in the neighborhood, as well as the option to participate in a community that comprised both housed and unhoused people. And the predictability of their whereabouts provided a place for various outreach services to find them, including medical, harm reduction, and housing organizations. By the way, I have no intention of beatifying this community, meaning turning them fully into saints. For life within Wood Street contained the various intimate forms of betrayal and violence one tends to find in such spaces of deep poverty and suffering. But these were matched or exceeded by the betrayals from the state, the city, the federal legal apparatus, and other various bureaucrats and politicians that had direct hand in their lives. Governor Newsom had singled out the settlement when he earmarked $8 million for the city of Oakland to sweep them and move residents to a 50-unit tiny home temporary shelter on the property, which had yet to be built on the northern end. The governor publicly exhortated in press releases the local officials, the advocates for filing temporary restraining orders in federal court, and the federal judge's various days of evictions, but of which he would eventually rescind, allowing the sweeps to occur under the guise that the temporary tiny home shelter units would be available to house the community, while at the same time, the city stated that an affordable housing project on the southern end was also in the plans to be built, and that more would come on Wood Street. 2 years after the tiny home shelter was built, the nonprofit running the shelter abandoned it, leaving it empty. The affordable housing has 0 affordable housing units, and the only other development on the site has been a parking lot. Billions of state dollars have been directed towards managing homelessness in California, and on the ground, much of that management has meant eviction sweeps within a panic-inducing public health rhetoric. As the governor stated, in condemning one of the few fleeting victories of a restraining order filed by the Wood Street residents, quote, "Our roadways and highways are no place for individuals to live, and this encampment is risking public health and safety." My ethnographic and activist work with the residents, other volunteer-housed activists, and attorneys that fought for them, both in the courts and in the settlements. And this picture actually on the right is Osha Newman, who's an activist attorney and fundamentally one of my heroes. My ethnographic and activist work, and these are just volunteers who are supporting someone who's actually witnessing the destruction of her camper, which she lived in on Wood Street for about 6 years. And so you can really see sort of the support that this woman has. My ethnographic and activist work with the residents, other volunteers, housed activists, and attorneys that fought for them, both in the courts and in the settlements, traces how these interventions, framed as care, produce forms of violence, structural, everyday, physical, and psychological. I've been thinking about this through the medical concept of iatrogenic suffering, injury caused by medical intervention, and the legal idea of state-created danger, one of the primary tactics the attorneys use to stop the sweeps. Both help us see how state action, referencing a form of protection within a discourse of public health and public good, create the very conditions of vulnerability and harm they claim to resolve. This harmful contradiction was made even clearer by the 2024 Supreme Court decision in City of Grants Pass versus Johnson, which ruled that cities can enforce bans on public camping and sleeping outdoors, including against people with literally nowhere else to go. And this is actually an art installation put together, and I sit on a nonprofit called Where Do We Go, who our founder decided on that term because when people are getting swept, the question to the people who are sweeping them is, but where do we go? Because there's no place for people to go. Including against people with literally nowhere else to go, criminalizing their predicament, and therefore them without violating the Eighth Amendment's prohibition on cruel and unusual punishment. The ruling consecrates a logic that was already present at Wood Street, that so-called interventions meant to prevent social and structural violence instead multiply it, while residents themselves fight for a form of inclusion as rights-bearing citizens who seek agency over pathologized bodies the state and media circulate on their behalf. The residents of Wood Street do, as I said earlier, take care of themselves and others in their predicament despite the state's best attempts to silence their efforts. I want to now show you a small video, it'll be about 3.5 minutes, of my friend Mona. I first met Mona in 2019 when she had recently become unhoused following a fire at the house she was renting. Here is a picture when she first came to Wood Street to live, sleeping on a piece of cardboard outside a friend's RV. I don't know if you can see the RV in the back, which provided her with relative safety. Mona knew the eviction was coming. She wanted to sort through her stuff on her own, handle her things on her own, with people she knew and trusted. This, by the way, was her second major eviction in 6 months, and she'd been extremely anxious for weeks over it, having had daily warnings of the evictions, acts the city saw as compassionate, with various outreach workers passing out small bottles of water and cold sandwiches in brown bags, and which Mona experienced as dire threats. And so, can I see if this will work? Because if I just clip this, I'm just wondering if there'll be sound. Did it skip it? Oops, it's on this side, but not that side. You wanna? Can you just slide it over? Almost there. Oops, my bad. Good. All right. Can you, I don't think the sound is going through. No, it's only on the computer. While he's doing that, so this film is, or this clip is produced by, directed by Karen Creighton, who's a documentary filmmaker who's actually putting out a film called Wood Street, feature-length, a full feature-length documentary on the community, in particular focusing also on the final evictions that occurred. We good? Yep. All right. Although that thing's scary. It's doing our little circle dance. Is that why?
Well, it's not
All
going
right,
to
so right here, we're going to work right there.
I don't want your help.
There you go.
I don't want your help. Thank you. We're doing it. You could be here, but over there. But we're doing
We're
this.
going to start over here.
You're not finna touch my stuff. You're not.
We can clear the stuff in front so it can so you can hook up.
I'm gonna move it, not you. That's my stuff. And the more I stop,
you.
I don't want
We
your
can.
help. I have my help.
Here.
Stop it, please. You antagonizing me,
okay.
and I'm gonna walk
I don't.
off.
Okay, this area. The
I
last
don't know
area.
what you're getting
I understand
on.
this
So
is.
go check off somewhere else.
Okay.
At this point, it's not.
Okay, we're gonna right here. We can work together. We can start loading up the stuff.
He see me moving. He see me doing shit. No, I'm tired. I want to talk to their supervisor. I don't give a fuck.
You got 40 advocates standing around. They can help her move her stuff.
To be honest, your presence is triggering her, making it harder.
Yeah, I understand. Yeah, I understand this is very tough. I think what would be helpful for her is getting the rest of their personal property up out of Charlotte.
Working.
All right, so let's keep working on it. Keep working on it. 100% keep working on it.
The stuff that you're gonna clear is cool. Let's get the area. It could be right here, and then right here. Let's start clearing this area right here.
But I'm not finna do that on your turn.
It's okay. You don't have to scream. I'm right here.
Okay,
Right here.
move,
I'm not screaming
please.
at you.
I did all this by myself with their help. I don't need your help. This is my shit.
Okay.
I say where it go.
Okay. Put it on your trailer. The goal is to clean up right
Come
here.
on. No means no. Leave me alone. Why you feel like raping me today? And y'all sitting up here letting them. Are you
Don't touch
doing?
me.
What are you doing?
Don't touch me.
What are you
Look
doing?
at- Don't touch
What
me.
are you doing?
Excuse
What
me.
are you doing?
Excuse me.
You antagonizing? You antagonizing? Please don't touch my stuff. Please don't touch my stuff. Please don't touch my stuff. If I need you to take it
Come on,
away,
right here.
then you take it away. You want this? Take it. Take it. Here. Steal it. Buy. Go. What else? Why the fuck do I gotta keep on saying the same shit over and over again? Why?
We over here. Want to keep this.
I'm working with you. Leave me alone. And y'all sitting up here saying this shit. Don't make no sense. Don't make no sense.
It's at the level of harassment.
I mean,
Triggering her over and over again.
Looking at what words.
Why is he fucking with me? Why? Why? Why?
I acknowledge
You and I don't live this kind of life.
and I acknowledge that.
So she trusts
This
us
is a
more than
closure,
you.
okay.
She trusts us. So if you let us help
Okay,
her,
come on, come
it
on.
might take a little longer.
We are.
It might take a
You're
little longer,
raping all of us right
but
now.
it's actually going to go more smoothly.
How do I go back to? Yikes. Hold on. 1 sec. This just went to here. Okay, now we're good? Okay. Now I want to read a short vignette, an ethnographic vignette from the same moment. As Mona's anxiety and fear increased, as her world was being obliviated, witnessed in her confrontations with DC, the coordinator of homeless services for the city, DL, the head of facilities management, a social worker and law enforcement, OSHA continued to try to intervene on her behalf, pleading with them to finally cede her wishes to leave her alone and let us, the advocates, just help her gather her belongings. She had been so traumatized over the years by these city's workers' presence that she just wanted to do it herself. This was completely in line with who Mona was, an extraordinarily hard worker and devoutly self-sufficient. Her extreme suffering in the moment was visible, in fact, unbearable. I looked over to see Karen, the filmmaker, covering her face in tears. We feared Mona would have a seizure or enter cardiac arrest. Mona, scared, pointed out that her veins were popping out of her neck. We tried to appeal to DC, his sense of decency over the torment we were witnessing, to just leave her the hell alone. And when intervened, pointing out to DC that she was so upset that she appeared to be foaming at the mouth, her mouth so dry from her pleading, he repeated, "Oh, really? Foaming at the mouth? Foaming at the mouth." And then, turning to a cop, asked, "Has mental health been advised? Maybe we should call in a 5150. Oh shit, I said to myself. I think I just messed up. Mona's eviction highlights another dimension of this violence, the weaponization of healthcare as if her visible anger and agitation, her resistance, could be transformed into a medical emergency to justify removal. They threatened her with psychiatric hospitalization, 5150, a mental health hold, which is triggered when someone is determined to be a danger to themselves, danger to others, or gravely disabled. Weaponized in this case for her own good, this was in no way an offer of care. It was a coercive threat, a way of leveraging the authority of medicine and one strictly within the bounds of law enforcement, to silence and displace her. In this way, healthcare itself becomes an instrument of state violence, folded into the logics of the eviction. What should be a site of care becomes a site of discipline and trauma, and yet another example of the cruel paradox, another iatrogenic harm in the form of an intervention framed as protective that generates visceral suffering and deep distrust. Now, going back to the 5150, maybe DC, the coordinator, was right. Maybe instead of inflicting self-harm, it was harm to others. And in this case, and through her resistance, she was causing harm to the institution of the state. Resistance is not only a dramatic confrontation, although at Wood Street that happened for months. Nope, it's not clicking through. Here we go. Millions and millions of dollars in police activity and overtime, hundreds of activists mobilized. It was covered heavily by both mainstream as well as the independent outlets, mainstream press as well as independent outlets. Helicopters loomed, bulldozers and garbage trucks, and hundreds of temporary workers, most of them undocumented, were employed to rake, sweep, and dump. And if you can go back here, this is a moment where Jason is just trying to get as much stuff as possible, literally, as the workers who were hired just as day laborers to just take his stuff. So he just had moments before this dissension came on. And these are just some more practices of acts of resistance. Here's Lydia, who is sitting down in front of a truck so that the truck can't move. These are scenes from another. Actually, when the sweeps first began, hundreds and hundreds of people were mobilized. And this is Jazz on a truck that was placed in front of the workers, in front of the Caltrans workers, so that they couldn't come in and start taking people's stuff. And this is an act of civil disobedience by one of the Wood Street residents. Her name is Jazz, and we can see her getting arrested here. And here's another shot of Will, another person in front of a garbage truck, so it can't move in order for it to, go and collect their goods. Arrests were made, and eventually the clearing's successful. The violence of sweeps is not only spectacular, as our other panelists will also discuss, it enters people's daily lives by, for example, throwing away prescription medication, breaking up close physical social networks necessary for support and survival. For example, during the opioid epidemic, there was not a single overdose death at Wood Street, as there was enough, and this is the community which had a lot of drug use. And there was enough people with Narcan and charged cell phones to respond in an emergency. And when the camp was finally swept, there were 2 deaths in the preceding month. The sweeps that lead to destroying documents necessary for various housing and social service applications, IDs, social security documents, etc. The sweeps undermine trust and service provision. People have been made promises for years that continue to be unfulfilled, not to mention making it impossible for various outreach services to locate them. And resistance to sweeps, and therefore as a therapeutic to the iatrogenesis, is also not necessarily in the spectacle. It looks like sharing food, friendship, together, tending to your home. These practices may appear small, but they are not. They are the infrastructure of life and conditions where formal, deeply mistrusted systems feel as though they act purely as systems of control. They are the counterpoint to the iatrogenesis and state-created danger, acts of resistance that the unhoused themselves create, a place, following Paul Farmer, where the distal and proximal merge, a site where care and social action converge. And this is an image after one of the sweeps was successful in an area that was just filled with people's belongings. Hundreds of people lived here, and they were actually literally up all night trying to help people remove as much stuff as possible. So So to name eviction as iatrogenic is not only to expose its harms, but also to raise the stakes of resistance. If the state insists on producing suffering in the name of health, then residents' ordinary practices of care and the struggle for that care become political acts. Iatrogenesis and resistance are two sides of the same reality at Wood Street. And at Wood Street and at unhoused settlements throughout, residents refuse the terms of disposability imposed upon them. They reveal that unhoused people are not passive recipients or just victims of failed policies and interventions, but active agents in their care, in the very shadows of our freeways, our streets, and in the face of the state. Thank you.
Thank you very much, Jeff. I should point out that Jeff was instrumental in organizing this quarterly conversation today, and we're grateful to you for that contribution to the program. Also, think about what Dr. Schoenberg was saying from the standpoint of global health as an interdisciplinary undertaking. This was a description from the standpoint of anthropology and ethnography of the lived experience of suffering and resilience and resistance within a community. In this case, a community of homeless people, which itself exists within a larger community of the city, right? So that gives us a particular perspective. Now we move to a more clinical perspective in terms of providing services and supporting the health and well-being of the homeless people by a presentation from Dr. Patty Gonzalez Zuniga. She is a Tijuana native, binational clinician with more than 30 years of experience working with underserved and marginalized populations in the U.S.-Mexico border region in the field of HIV care, with interest in HIV prevention from a public health perspective and the barriers and risk factors, individual, social, and structural factors, that is, that prevent access to prevention and care for individuals that recently acquired HIV infection in the drug-involved populations. She's a co-author on several publications. In 2014, she became the founder and director of the Wound Clinic, an independent mobile street-based effort. She's worked with trainees of all levels from Mexico, Colombia, Brazil, Canada, and the United States, and offered accessible education regarding the clinical aspects of infectious disease management, wound care, trauma-informed structural competence, and compassion. She orients volunteer medical students and undergraduate students, to the nuances and challenges of clinical care and accompaniment for the patients we served. She leads outreach efforts to provide clinical care in challenging circumstances. She's debriefed regarding learning points from the day with learners to provide an overview of the U.S.-Mexico border and principles of harm management. She has also served as a board member of Women and Harm Reduction International, the Latino Coalition Against COVID-19, and recently was invited as a speaker in the Global Health Assembly organized by Doctors for Global Health in Santa Monica, California in the summer of 2025. Patty has been with us here in the quarterly conversations before, a couple of years ago, and you both were here as part of that a couple of years ago, and so we warmly welcome you back for a second round.
Hello, good afternoon. Thank you, Dr. Sordas and Jane, and all of you who are here. to talk about something that we always think that we will do better. And time passed, 2 years, or 3 or 4, and we hear the same, the same situation for people who everybody consider, not everybody, sometimes the state or the society, like los que no son, those who are not, or considered subhuman. And so it's a pleasure for me to be here and to share a little bit of our experience in the wound clinic. And I'm gonna skip this because it's long. But we wanna talk about the interactions of immigration policy in substance use, sex trade, and health in the Mexican border side. Also, as Dr. Jeff mentioned, the structural condition that marginalized communities, deportees, and persons who use substances experience accessing care in Tijuana. And understanding the unique role that harm reduction organizations, we don't have many, such as the Wound Clinic, play in increasing awareness about the urgent need for humane and respectful interventions that include mental health, substance use, treatment, and for marginalized communities in Tijuana. And I'm gonna give you a quick background of what is Tijuana and what is our border city. In the last 10 years, population grew fast, 23% from 2010 to 2020. Some of the reasons were that migration, deportation, and in the late 3-4 years, internal displacement from increased violence in Mexico. So Tijuana has been always a city where used to be a welcoming city for people who were coming from different places, but now it has been really hard, becoming hard and hard. From 2016 to 17, we have a huge community of people from Haiti. I always hesitate to use numbers, but sometimes we need to use them. 6,000 people from Haiti came, and with the intention, asylum seekers, with the intention to come across, but 3,500 stay in Tijuana. Then after, from 2015 to 2019, 6,000 people from Central America in the second caravan, and 2,000 stay in Tijuana. And then recently, from the last few years, internal displacement for as I mentioned it, the increased violence in states as Chiapas, Guerrero, and Michoacán, and Sinaloa has been pushing people out of their lands and try to find a better place to be. And Tijuana, unfortunately, is not a better place to be. We have, a few years ago, I hear that Tijuana was like a melting pot. So I don't know if it's a melting pot, but it's becoming more, it's a hardship every day for people who are living unhoused or just arrived as migrants. We have the higher prevalence of HIV and AIDS cases from Mexico. At the border, it's estimate that from 10,000 to 15,000 cases. Drug use in comparison to the other places, we also have first places. Tuberculosis also is another. HIV is from 4 to 7% prevalence and 1 to 2% incidence. And this is a study that Dr. Stratti and collaborators did a few years ago. Only 10% of people who have HIV are receiving treatment. And so this is Also, some social structural context and its impact in health of people who inject drugs in Tijuana. It's a transit hub for migrants and deportees. Also, in Tijuana, it's a semi-regulated sex work industry. Also, trafficking on heroin, methamphetamine, and fentanyl route, and it's a high rates of violence by organized crime. And so these are like some of the structural factors that are conducive to drug use. I'm just gonna mention that in Tijuana, there are like 37 shelters. Usually shelters in Tijuana is faith-based run or NGOs, but the requisite for those shelters is to be clean. So a lot of people who use substances are not allowed to be in the shelter. The government recently have like what they call migration station, translated to detention center in Tijuana, and we don't know where is it. It's in the books and it's in the, when the politicians do like what they do reports, they mention all these strategies, but when you go and actually try to find, actually where things are happening, they were there or they disappear or they're not working anymore. They also have like, when the caravans, they try to do like what they call Centro Integrador. It's like a migrant shelter, and they were saying that was like a space for 3,000 people, but only were providing shelter for 400 people. And I think only lasts for the time that there was a lot of media where the caravans were coming, and then they changed also the routes of like deportations and routes of where they were deporting people after the COVID and so. Also, there's 250 rehabilitation programs, and those I add for profit because they run by even family request, or the government provide funds for them to run it. But there are several articles that they say that are places for mistreatment and torture, decomposing food, humiliation, and unsanitary condition are just some of the techniques they use in rehabilitation centers in Mexico for the treatment of people who use drugs. And a few years ago when I was working at the with Dr. Strati, we used to go and visit rehab centers, and we witnessed like how cruel some places were. I really remember going to a place where was a small place like a home with a couch, and in the middle of the room they have like a wooden house with no windows or no doors, but just like a little room, like a wooden room. And so we were sitting there and talking to the person that was running the rehab, and we started hearing noises. And we were like surprised where these noises come. And then we got and see like a little window, and then inside the little window we imagined there was a person. And we started to talk, and he said like, no, I'm here because I was behaving bad. And I said like, how come? And I said, yeah, I was using drugs and I was really, not doing good. And I asked like, how long have you been there? And he says like 2 days or 3 days. I don't exactly remember, but there was no bathroom, no anything. So you can imagine, no light, and that's how some of the ways that they do rehabs in people. Talking about healthcare in Tijuana, I'm sorry for the typo, I'm really sorry. There's only one public hospital and one hospital that provides emergency services, and it's the Red Cross, but also it's semi-private. They only provide free transportation, but the rest you need to pay for. If you have a surgery or you need to be hospitalized, you need to pay. And if you don't have money, they transport you to the Tijuana General, which is the public hospital. But also in contrast, Tijuana is the city with more private hospitals and clinics, has 95. And in the medical tourism, campaigns, they call it the Mexican Houston or the Houston of Mexico. It's full, Tijuana is filled with bariatric surgery clinics, ophthalmology, holistic spas, alternative medicine, cosmetic clinics, dentistry, pet hospitals, and clinics for pet hotels. Pharmacies also is the number one in pharmacies with 942, but very few or scarce harm reduction services for the unhoused. And those services are like with limited hours of operation, no weekends, no evening clinics, or no night clinics. So services for the unhoused and other marginalized communities are provided by faith or community-based organizations. And again, a structural condition that leads substance use, like sometimes when migrant came, they fall to the crack, they don't have sometimes documents, also especially when they deport them, they don't have documents, they don't count as, citizens. Usually when they do campaigns, the government do campaigns for integrating people or to provide care, but they ask for the ID, they ask for what they call CURP, that is a national identification number, and a proof of residency in order for them to receive state care. So a lot of people who are migrants or are being deported or are unhoused, they don't have any of these, papers. They suffer from isolation, anxiety, depression, despair. There's also a lack of trust for existing healthcare systems. So in our experience with the clinic, when we see a patient that is very ill or needs to be hospitalized, usually the patients will say, I don't want to go. I'd rather stay on the street. Please don't take me. Please don't, because I know that if I go, I'm going to die. So there's a, mistrust, but also like they've seen so many people from their community that die when they go. And I'm not going to say that they caused the death. Sometimes they're very ill, but a lot of people who goes to the hospital, they're very advanced and they don't come back, so they never have time to say bye or to see their friends again. So in 2015, there was also like a similar displacement. There used to be a community of people who were living in the river basin of the Tijuana River, and so they displaced. We used to have the clinics inside the canal, and they were having the city have money from the federal government to provide rehabilitation and to relocate this community. And so what they did, they came and they took everybody to rehab centers. They give money to rehab centers, and sometimes people that were not using drugs ended in rehab centers. We were visiting some of the rehabs and tried to find people who were living in the canal, and we couldn't find a lot of them. Sometimes they were taken to the south of Baja, to the middle, places in the middle of the desert, just leave them there. And little by little, as the time came by, we started finding more people, few of them. And it's for us, it's always a big moment when we find somebody that is lost and then we see them, oh, you're alive. So it's like, it's our good outcome when we find somebody that is lost and we, through the years we find them. But yeah, people are like, legal documentless, houseless, jobless, familyless, communityless, living sometimes in areas that are uncontrolled from the cartels and gangs, to do like sex survival, sex work, and sometimes the only way that they can support themselves or economically is like even working on the streets as like, you know, recycling, or start doing like drug dealing, like narcomenudeo. And then, so they start, sometimes they get like drug credit, like small amounts, but if they don't pay back, they owe the dealers. And so it's like they're engaged in a very risky and sometimes death end. So I'm gonna excuse this. So what motivates us to create the wound clinic? Well, what I was telling you, like all the scars and hard to implement harm reduction services, limited clean syringes, no running water, aggressive police tactics, lack of understanding of what is true harm reduction. Because sometimes we think always like is the harm reduction, the medicalized harm reduction, like I'm gonna give a needle and that's okay as long as I give you a needle. But it's more of like accompany people and be with them and treat them with dignity and respect. Not think as they are a problem, not to think as they are like the tuberculosis case or the HIV case, but a person who has a condition. So we also partner with volunteers from that they were emergency medicine doctors, and together we think that emergency medicine skills are useful to treat almost all wounds and abscesses, but are not included in many of the harm reduction services. So our wound clinic principles are meet people where they are, but truly where they are. So our clinic has been displaced many times from different places in Tijuana. So we just move around. I think we last only like a year, and then we move around, and then we go where the community goes, and then we establish. So we're being kicked out from like many places in Tijuana. Sometimes we laugh. One anecdote that we have is like one time we settled our clinic in front of the courthouse because that was a nice space, and on Saturdays they're closed. So everybody was coming and everything. So like month after we were there, they put like big poles in the middle so we can park our clinic there. So we move and we find another place. And then we start like a campaign that we call Por una Tijuana más humana, for a more human Tijuana, because the city always have like Por una Tijuana limpia. So we don't have a lot of fans. They have more like for a clean Tijuana. And they keep repeating the same campaign. And it's like the campaign that they will displace people. So our mobile interdisciplinary harm reduction clinic delivers emergent and urgent medical care integrated with delivery of harm reduction supplies, education, and care coordination to improve the health care for this population. We used to go every week, but now since we are independent and we support ourselves by our group of volunteers, we do a monthly clinic, and we move around depending where people are. We provide free needles, disposal, hygiene education, food, water distribution, clothes, socks, and recently we add like the harm reduction boutique, and we have people goes and choose. I mean, we put like a rack and a rack with clothes, and we let them choose whatever they want. We never tell them take this or take that, and so we try to get very things in the items that we think that I will use. Those items I will take. It's the same for the food. We don't believe that the clinic is like a charity clinic, but it's more of a social justice clinic. So when we provide food or other items, it is quality that ourselves will have. Like I say, I will never give like a maruchan or instant soup because I know that it's not really good. So they taste good, but it's not really good for your health. So we don't do that. And so this sometimes what we do is like also art inside the clinic. We brought like chalks or crayons or markers. They draw whatever they want. We make makeshift or harm reduction supplies. We use pencil cases to put the naloxone to prevent overdose because we don't have like like the funding or to be like a really professional presentation, but we try to create things that can be safe for them, but also help them. And basically also like the main thing for the clinic is to create a safe space. People are being moving around every day, like they're not allowed to like sit or relax in the park benches that we don't have that many, but if people are been sitting there, then the police goes and move them. Unhoused people, they're not allowed to be inside government offices or some restaurants, like not even like, the fast food places, they're not allowed because they think that they don't look good. What else I wanted to say? Yeah, so it is really motivating to us. As a physician, I start like looking at harm reduction as to decrease the negative consequences of the use of drugs or prevent harm from illness. But for me, harm reduction is to provide respectful, to acknowledge a person as a human, to look at their eyes. I will remember that we have a good rule in the clinic. I don't allow to have like sunglasses with the volunteers when we are on the streets. And that's because like police in Tijuana, they all have sunglasses and they identified, people with like dark sunglasses as, somebody with power that will, and also somebody that will not look at their eyes. So we have this weird rule that we don't allow like sunglasses in the clinic. So our sustainability is through strong advocacy and solidarity support from friends and colleagues. And the WUN Clinic is able to keep reaching people who inject drugs and other unhoused with needed services. That little draw, I wanted to tell them like in a very simple way about naloxone. And so I didn't want to like elaborate a lot, so we did that drawing and said like, naloxone saved your life. You were like this before, and then you're like that after. So just very simple, like. And with this, I would like to thank you with this quote. Shame and stigma can coexist with compassion. If you can create a place for compassion, then you create the space where people can actually heal.
Thank you very much, Patty. Dr. Gonzalez Zuniga at one point used the word accompaniment. And I think this is a word that ought to stick to us, and it's worth looking into more, because harm reduction is not a transaction. Here's a needle. It is, and it's not just compassion, and it's not just empathy. It's an accompaniment. And this word means something, it has a history, it has spiritual basis, it has an emotional basis, it has an interpersonal basis, and it's not just walking alongside someone, it is being with someone. And the last thing that you were saying about the sunglasses, being with someone requires being able to make eye contact with them. And so it's not just a little thing to prohibit sunglasses. It's something that fully supports this idea of accompaniment and being with and care for something. So thanks especially for that presentation. Our final speaker on the panel today is Kate Pocock, MHSPAC by credential. She is the Regional Director of Clinical Operations for Healthcare in Action in San Diego. And she practices as a street medicine physician assistant. Prior to joining HIA, she was a clinical instructor of family medicine with USC Street Medicine in Los Angeles for 3 years. She has experience in street medicine operations and management, street medicine curriculum development and dissemination, quality improvement, and providing direct clinical care to unhoused patients. Kate holds a BA from the University of California, Berkeley, and she earned her MHS from Duke University in 2013 as part of the Underserved Community Scholarship Program. She's currently pursuing a Doctor of Public Health with a concentration in health policy management and leadership at Johns Hopkins University. We're very pleased to welcome Kate Pocock.
Bear with me 1 second. I'm going to do a quick change. Okay. Thank you. Hi, everyone. So I told Jane in advance, I'm a walker and a talker. I have a really hard time sitting in one spot, which is why street medicine is the perfect place for me. So what I'm going to talk about today is really trying to help round out so much of what we've already discussed. And so policy and funding really shape so much of what we do. So out of curiosity, who here has heard of street medicine? Okay, cool. So I'll tell you, that's pretty heartening because when I was in your position, street medicine wasn't even in our vocabulary. There were a handful of doctors and nurses that were doing street medicine pretty much out of Boston. You'll hear a lot more about some global conversations of street medicine, but now the community is humongous. So I've had the opportunity to present the last 3 years at the International Street Medicine Conference, and every single year it's bigger, it's stronger, more countries are represented. So for this audience who are really interested in global health, street medicine is not just in the United States. It really is a global movement, which is incredibly exciting. Today, though, I'm going to talk specifically to the United States. It's where I have a little bit more understanding of everything. Oh, you don't need to see my SD huddle. I'm going to pop that off really quick. All right. And I am going to put myself in. Sorry. Oh, you guys are, I'm not as IT savvy as I could be, but you guys are really good at it. It's in Canva. Cool. Yeah. Oh, great. You're going to mirror it. Thank you. Okay. Perfect. Thank you so much. I appreciate it. Okay. I'm going to keep going to save us some time. So, you're also going to hear how busy it gets in street medicine if you keep hearing that sound. Our team is very active. So, street medicine, a lot of people have some familiarity, but it's still kind of new to some people. So, what street medicine is it's along that spectrum of homeless healthcare service delivery. So, a lot of people maybe have experience before with hearing about mobile units. Some people may have heard about shelter-based care. Street medicine is really sort of that other end of the spectrum where we're trying to get out to the furthest person possible. The people who might not be able to access through the shelter, who might not be able to access through the mobile units, those people who are in the riverbeds, who are really far out there where those places, where those providers can't get to. So street medicine, sometimes you might hear referred to as backpack medicine. This is exactly what it is. It's us putting backpacks on our back with medications, wound care supplies, lab supplies, all these different things so that we can bring it out to people. Different street medicine teams have a really different service delivery, so not all teams are created equal. I'll talk a little bit about what we do here in Healthcare in Action down in San Diego. But what you'll see a lot of these teams are providing is primary care, urgent care, wraparound services, harm reduction services, and really, it's growing in a lot of great ways. Next month, I have an occupational therapist coming out with me for her capstone project. So OTs are starting to get into this, physical therapists, specialists. I had a nutritionist reach out to me recently. That's a fantastic person we need out on the street with us too. So if you're looking into anything in healthcare, it all belongs in street medicine. And with this growing community, there's so many opportunities. So for Healthcare in Action, we're a statewide organization. We're actually one of the largest in California. We're growing into some other states here in the future too, so it is a growing team. What you'll know too about lots of different street medicine teams is they're different based on who their supporting institution is. So up at the University of Southern California, I was at an academics supporting institution. HIA is actually supported out of SCAN, which is a health plan. Kind of seems like a surprising organization to support street medicine. But believe it or not, a lot of the health plans are really interested in how to do this. We'll kind of talk about that in a little bit. You'll also see some street medicine teams out of federally qualified health centers. You'll see some who are also just physicians or other independent providers putting a backpack on their back and walking outside to take care of people. The spectrum is vast. So for us at HIA, our team down here has 32 peer navigators. And we have 3 APPs, 2 nurse practitioners, and 1 physician assistant. We have a medical director, and then we also have what are called clinical service specialists. And so those are going to be people who are like EMTs, MAs, kind of in that really supportive role for the clinical team. For us, the peer navigators that I talked about, those are case managers. So we have 2 kinds of case managers. We have enhanced care management, and that's going to be those folks who are really designed to be helping them discover an entire plan for how to serve that person and that whole person. They're not just showing up and saying, what are your medical needs? They're saying, what are your social needs? What are your transportation needs? What are your food needs? Also, one of my favorite things ECM care managers do is, what are your family needs? A lot of unhoused patients, people don't realize, still have a strong connection to their families. I really discovered a mother's love when I started taking care of unhoused patients. I had one mom in LA who went out and visited her son every single day. And so those enhanced care managers do so much. They do that whole person care from start to finish. Our other group of peer navigators that we have, they do community supports. Now, this is a whole group of, there's about 12 different buckets, but what our team focuses a lot on is housing support and housing navigation. And there is so much to that too. It's not just the case of we need to get somebody inside. It's you have a voucher, how do I connect you to the right place? How do I make sure that the place that we might be able to provide housing is gonna be able to accommodate you if you have any sort of accommodation needs? How am I gonna make sure that your pet gets to go inside? Right? One of my favorite colleagues out on the street are the street veterinarians. If you're at any interest in veterinary school, go to it. And if you want to do street medicine, you can be a street veterinarian. They are some of the most visited groups when it comes to any sort of major events where we're all in the same place. The street vets are the most attended group. So that's really what our team is working to do. And so we do primary care, urgent care, and then those really comprehensive wraparound services. And we can also do a little bit of an a la carte. If somebody already is established with a brick and mortar clinic and they're doing really great work with them, we don't need to start getting into any of their clinical care. We can really just focus a lot on that enhanced care management and those community supports, and vice versa. If they don't have a brick and mortar and they do need access to healthcare services, then we can serve them. And they don't necessarily have to use our enhanced care management or CS if it doesn't serve them best. So also, just in case you didn't notice, I really, we have 10 to 15 minutes to talk, but I have so much that I could say. I like to QR code the corner. If you see anything or if you hear anything I've talked about that sounds really interesting, grab that QR code and it's gonna connect you to the resource where I'm talking about. So, from the policy to the street. So this is really, really important for us to be talking about because in the last 5 years especially, I think one of the key reasons street medicine has grown is because we've actually seen a lot of policy support. A little bit of it at the national level and a lot of it at the state level, all right? So California is really one of those front runners when it comes to street medicine. Massachusetts, Hawaii, some of those states are also doing really great, but I would say that California is sort of the epicenter of the growth, especially when it comes to policy, all right? So one of the key things that came out was in 2023, the Department of Health Care Services actually released what's called an all-plan letter. An all-plan letter is a way for them to provide guidance out into the community. Specifically, this one was for managed care plans. Managed care plans are the insurance companies who are tasked with providing those healthcare services to Medi-Cal beneficiaries. Every county has a different set of plans that are doing it. Down here, you might hear things like we have Community Health Group, we have Molina, right? Some of these maybe ring a bell, Blue Shield. Those are gonna be our Medi-Cal plans down here. So this all-plan letter essentially said, hey, you should absolutely, and you can, contract with street medicine providers, and you can start using that as a resource for how you deliver services to unhoused beneficiaries. So this was sort of step one. This was a good opportunity for us to really start to see how street medicine was gonna shape. But it didn't necessarily give the how. It gave the yes, but not the how. So that's where some of these next steps came into place. And this one was pretty critical. This is actually at the national level. The Center of Medicaid and Medicare Services, CMS, actually gave us what's called a place of service code. Now, this is an opportunity for us to legitimize that street medicine care, the care provided on the street, is acceptable, and that is considered an actual place where you can deliver healthcare services now. So from sort of a boring standpoint, it means I can bill and show you that I provided care on the street. But from more of that comprehensive understanding, this also says, yeah, it's absolutely okay that you're providing care on the street, okay? So this came in 2024. So you'll see these are relatively recent. This is really, really new stuff. And even most recently, as of this year, as of just a month ago, one of the sort of really big bills were passed, AB 543. And AB 543 is really us getting to the how. This is us getting to how is street medicine going to actually operationalize in a way that's really meaningful to the teams that are providing the care. So I'll tell you, I've been practicing street medicine in California now for about 4 years, and I've practiced prior to that on the Native American reservations in Arizona, kind of accidentally, but it seems like it should be me being able to walk out and take care of people, right? I know how to practice medicine. I've been practicing for 13 years. I can do that. There's so many barriers to that. When I go out and I see somebody and I want to prescribe them a medication, I have to figure out how I'm going to get that medication to them. I have to make sure they have insurance. I have to make sure they have a way to pick it up. If they don't, I'm going to try to figure out a way to get that to them. Now, let's say I want to order an x-ray on somebody. For you or me or somebody who has a resource, it might be just walking in, getting an order, and going over to the radiology department, right? But not for our patient population. I can order that x-ray, but it doesn't mean that it necessarily is going to go directly to a place where that person can go and get that x-ray done. I can put it in my system, but it doesn't mean that that's possible for them to get it. So it's the case with all different imaging. So we have CTs, MRIs, all of those take extra steps. Now let's say I want to get someone to the cardiologist. It should be something, we know it's not always super simple, but it should be a referral. But for me and my patients, I don't necessarily have a referral system immediately set up. So that's where this is starting to step in. That's where this is starting to say, this is how we're going to build the infrastructure so that all those folks who are out there doing street medicine are able to actually connect those patients to services that they are supposed to be getting, right? And so AB 543, one of the key things that it did was it established a rule for presumptive eligibility. Presumptive eligibility is the way that we get to say, by identifying anybody who's unhoused, we should presume that they are Medi-Cal eligible. And so for that exact reason, I can start working with them right away. I don't have to wait for them to get that insurance. I don't have to wait for them to get assigned a plan. I don't have to wait for all these things. I should be able to access or to start getting them that care right away. Which for those of you who may have worked with any unhoused people, sometimes it's right then and right there that you're able to get that work done. If they get swept, I lose them. If they get incarcerated, I lose them. There's so many opportunities for me to not have that opportunity for continuity of care. So this is really, really critical for us to do this. It also helps us establish early trust. So many of our patients have been promised things that have never been delivered to them. But if I can tell them I can do something and then I do it, I am absolutely developing a relationship which hopefully will have a longitudinal relationship. We'll be able to see each other for years. Up in LA, I had been taking care of my same set of patients for 3 years. You go through so much life with them, and you do so much care with them, and it gives them so much meaningful opportunity to have so many connection to services. We can be one of those central people for them. So now the funding piece. Big conversation these days, right? We're all pretty familiar with the fact that there's a big shift happening to how funding is done in the United States. So let me tell you how street medicine has been funded historically. So we developed a financial planning for street medicine toolkit, which was really designed in a way to help street medicine teams figure out how to diversify all these different funding streams. Because I'll tell you this, street medicine is not just funded off of us billing for our services. It's much more complex than that. So we really lean into Medi-Cal. So for us in the state of California, we have most of our patients are going to be Medi-Cal eligible. Now here's the key, and you've probably heard this quite a few times. The Medi-Cal and Medicare rates are really not great, right? And when you look at how much it costs for me to have my teams out in the street, it's a lot more than a brick and mortar clinic, right? In a brick and mortar clinic, when you have 20 patients that show up in the lobby waiting to get seen, you can make sure that you're seeing people and you can bill accordingly. For me and my teams, when we're headed out to see people, I might miss someone. I might not be able to catch someone. I might have a really long visit with somebody because they're having some sort of mental health crisis. So it's a really unpredictable schedule, and as a result, it's really tricky for us to have a really set budget. What that means is, for us, those Medi-Cal rates are a lot less than what we really need. So what we're working to do is try to contract with the plans to actually see if we can't get a little bit more, to see if we can't show them, hey, the work that we do actually requires this amount of money, right? And this is really tough. It's a tough conversation to have, but it's the way that we continue to sustain ourselves through Medi-Cal. Now the second, and this is a really key thing to understand about Healthcare in Action specifically, so the organization that I work for now. So CalAIM is something that the Department of Healthcare Services launched about 4 years ago, And this was an opportunity for us to pull all those social determinants of health, right? I know you've been hearing that word over and over, or that term over and over again, but this was California's way to try to say, hey, all these social determinants of health impact health so much, we're gonna pull this into the Medicare delivery, or the medical delivery system, all right? This is how we're gonna make sure that people who are on Medi-Cal have access to housing opportunity, have access to dietary opportunities, have access to so many different things. So for us specifically, those peer navigators that I talked about, my enhanced care management case managers and my CS case managers, they're specifically working directly for that program. So these can work in tandem, and it's a really great way for us to have those wraparound services for folks, but also make sure that we're able to bill for all of these different things that we're doing. So one of the other things that we really focus a lot on is there's a lot of grant funding that we have to go after too. Now grant funding looks very different in this day and age, and so we're working on trying to figure that out. I wish I had a really clean, beautiful answer to tell you exactly how we're pursuing it, but we don't. Right now we're working to pivot and try to figure out how to do this, all right? But for the historical last while, these were kind of the key ways that we were able to fund the work that we were doing. The last one, too, is you're supporting institutions. Some supporting institutions are able to help make sure that their street medicine programs are able to sustain themselves. But I think across the board, the sustainability is a big question. It was a question for the last few years, and it's a big ongoing question. But I'll tell you this, I'm pretty optimistic. I do think that there is a lot that's in our favor, especially in California. So I know that funding and policy can glaze people's eyes over pretty easily, and I totally understand that. In fact, when I sat in your seat not too long ago, I probably thought there's no way I would ever go into policy and management, and here I am. But here's why this really matters. All the things that Patty and Jeff just talked about, the people, the healthcare, the humanization, all of those things are exactly why we do all the rest of this, all right? We can't do the work we're doing without policy. We can't do the work we're doing without funding. We can't do those things. All of it is interrelated. And so when I'm looking out here and I recognize you are all really at the start of your careers, I just want to tell you this. When I was in your seat, I thought there were maybe 2 pathways to get to do something like this, but it's absolutely not the case. If you want to go into policy, you want to go into funding, you want to go into public health, you want to go into medicine, you want to go into nursing, all those things lead to the same thing. But at the end of the day, that all leads to one most important thing, which are the people that we get to serve. And so I just can't tell you enough how excited I am to see such a full room of people, because I tell everyone all the time that your generation will solve everything we couldn't. Cool. Thank you.
Oh, that's it, okay. So, just one more reason to be thankful we're in California, right? Okay. I'd like to invite Patty and Jeff to come up to the podium, and we will open the floor to discussion and questions. Who wants to be first? Yes. Hold on a second. We've got a microphone coming for you.
Hi, thank you so much for your talk today. It was very emotionally stirring and impactful, so very grateful for you guys and all the work that you do. My question was, how do you balance your own sense of mental health and empathy and just the emotional strain it goes behind doing all of this work? Thank you.
I'll start. Sometimes when you're engaged in some sort of social justice sort of fight, I think my talk was really, I tried to sort of center it on eventually the resistance that they were doing. And the resistance, the resilience, the strength of folks there really does provide, you know, and I don't want to sound self, but provides me with some strength also. Also, part of it is just resigning the fact that it can be really rough, and you just, you know, there are times that it's just difficult, and so, you know, go to therapy, have a community, talk with your friends. This community itself, for me, was actually fairly unique. I've been working in unhoused communities for many, 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 many years, and this was actually a very unique supportive space. Both from the folks who lived there, from the house folks who came in, and it in of itself did provide it. But sometimes, honestly, especially given our political climate, it just sucks, and you just feel terrible. And you just got to recognize that you're going to feel terrible sometimes, and you're going to feel elated sometimes, and you just keep fighting.
So I can't echo enough exactly that. But I think I have two other things to add. I think one of the key things that has helped me the most is growing my vocabulary of understanding so much of this, understanding things like the difference between grief and trauma, and understanding that there is vicarious trauma, and kind of breaking all those things down. By knowing what those words are and assigning that, I can understand my emotions so much better, and it really helps me delineate so much. So a lot of that's through therapy, and a lot of that is also through just learning as much as you can. By nature of asking that question, I think that's already a great sign. The second thing to say too is that you gotta take the good with the bad. So, you know, this week I lost a patient who I've been taking care of for so long, who had Huntington's disease, which is debatably one of the worst genetic diseases someone could have, and then to suffer that on the street is just awful. But this week I also had a patient birth a beautiful baby girl and go home with her. So you gotta take the good with the bad too.
For me and for our group, for our community in the clinic, is I think facing the challenges of being working in health institutions and see how sick they are. Like when you're on the street and when you're people who are living and survival and have that resilience to fight every day, and they don't get, I mean, they get tired, but they don't take it as like, imagine how many of us have been without a roof. I mean, when you're not camping. And if you're camping, you're taking all your, you know, utensils and like the tent and all that stuff. Well, they're camping with nothing. And they're like waiting for them to be pushed around. So they need to be in alert all the time. So when you go there and when you talk to them, you get back a strength, and they're not always easy. Sometimes you feel sad with them, but also you remember that you're alive and that you have a strength also, and it's like kind of an interchanging of a good energy, I think.
Thank you so much for all your shares. I was wondering if maybe you could just share one particular circumstance where the care that you've given, where you really have seen it, like really help someone, like a particular individual.
I have one. This was in Los Angeles. I was just driving around actually with one of my, so up in LA, we have community health workers are pretty integral in the street medicine community up there. And he and I were driving around, and we just happened to see somebody on the side of the street of one of the overpasses where we sort of historically really were, and I'd never seen him before. You kind of, when you drive around, you get used to seeing a lot of the same people, and I'd never seen him before. But what I immediately noticed was he had what's, has anybody, you've probably seen this, sort of, it looks like a halo on a leg or a limb. And so that's an external fixator, and he had that on his leg, and I could see from a very far distance that it was incredibly infected. So we pulled over, and we stopped, and luckily, he was willing to engage with us quickly. Sometimes those relationships take weeks, but this one was one of the ones where we got lucky and he was willing to engage fast. And what I came to find out was that that had been on his leg for a year and a half. Now, historically, those are only supposed to be on for a few weeks. He had tried to access care 3 times to get it taken off. The first one, he'd been accused of drug seeking. The second one, he'd been held down and he described multiple IVs put into him. Now, he may have been quite sick, but it's really tricky. Either way, he felt incredibly disrespected. And in the third instance, he got drug sick while he was waiting in the waiting room and had to leave. So in all 3 instances, he tried to access care but couldn't, and he had just resigned himself to the fact that he was going to lose his leg, and he was quite young. And so we built a relationship. He wasn't willing to go in right away, and that was okay. So the 2 of us spent a lot of time. I identified a lot of his other goals for himself, and the 2 of us just started working on it. And over the course of a few months, we got to a point where he was comfortable to go in. And he went in, and he got it taken off, and was able to preserve his leg, and actually fired me after that because he said I needed to go take care of other people. But he was able to ride his bike, skateboard. His major goal was he wanted to skateboard again. And so we were able to get him back skateboarding. So, you know, that's not necessarily, everybody always wants to hear the instance of the housing and all that kind of stuff. I've got those stories too, but I think he always stands out to me as somebody who we identified his goal, and that was skateboarding, and we were able to get him back to it.
I just have like last week, I knew a young girl that was like living on the river canal using heroin. And we were the chance to talk to her, you know, to see her. And at that time we did an HIV test and she was positive, but she was using also. And so she was coming like, I never push anybody who has a test to say like, oh, this is the end of the world, you have HIV, you're gonna, because there's a lot of stigma still around HIV, even like 40 years ago, and a lot of improvement in treatment, but a lot of, still in the society, there's like a stigma, a strong stigma. And so luckily this girl, it really complicated for people who are unhoused to get them in treatment. And luckily, she was, her father was living on this side. And I just talked like 2-3 weeks, and I said, oh, well, will be a good idea if you know, start looking to ways that you can get treatment. So time went by. She called me probably like a couple months after, and then she said, oh, Doctora Patty, I went to the clinic. And I said, oh, good. So she started her treatment. But then I lost track of her. And then she kept the phone number. And then like a year after that, she said like, oh, you know what, I move in and start living with my family, like my mom and my dad. And she moved to her family here in Imperial Beach. And then I said, oh, that's so good. Well, I'm not gonna make this story long, but through the years, I have like contact with her just to say how are you, how are you doing? And then for, this is when I met her, like probably was like 8 years ago. And now she's working in the same place for 8 years. I don't know if that's a good or not, but she has a stable job. She had insurance, and she got married. And also, what good outcome for me was she was calling me to see like what kind of insurance she should choose. And I said like, oh, how come? She said like, no, it's because I got married and I need to choose like a good insurance because I really wanted to keep going with my antiretrovirals, and that's the most important thing, and I wanted for like to live longer and all that. But she's good, she's like looking for her own care, and she's happy. And then she called me and she's like, oh, I got it. Like I talked to Human Resources and they told me that my insurance is not going to be that expensive and I'm going to be okay. So, like from being to the streets, it's not a very many of those cases, but I count with my finger. And I think good outcome is to find somebody alive, is what I think.
I'm just going to speak briefly about the moment that I showed in the clip and spoke about. And so we finally were able to help her move her stuff to just another spot. And there were, by the time that was done, and this, we went on through the night, actually. They ended up getting frustrated with us, and the city ended up leaving. But we had to promise them that we were going to actually move. And so we did, and so we were up till, I don't remember what time it was in the evening. We didn't completely finish, actually, now that I remember. It took us another day, and they gave us that day because they saw, I mean, we were, I don't know if anyone's ever seen something, but we literally had, chains underneath one of our RVs, and we're like trying to get it out of holes, and people are pulling and pulling. And there were about 8 of us finally, but just even that evening, that we were just able to hang out with her. And we got food, and she had this she loved this, she didn't drink really that much. And so we got some ginger soda that she loved from Safeway, and we got some takeout. And just the fact there were about 7 of us, into the night, just hanging out with her. And that didn't go, unrecognized. She was incredibly grateful for it, incredibly grateful. But just that we could be there in that moment to be able to provide her with at least some sort of sense of calm. And again, the recognition that she had people who had her back. And, so many times, folks who are in those predicaments, there's not a lot. And I think one thing I was trying to get at Wood Street is what made that sort of space so strong is that you felt like people had your back. And especially when you have something as powerful and as strong as the state coming down from you, and you have constantly, and I mentioned it, and I know sort of Kate mentioned this idea of disappointment, which is just rampant in people's lives, promises, 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 they're going to do this, and nothing happens, and nothing turns out well. And again, it was getting at, it just turns out, more violent, more traumatizing, and anyhow. But again, just so that we could be with her and allow her to be calm and recognize that. It's those sort of small moments that I think that, really oftentimes stay with me.
We have one person on the aisle over here, and then one person in the corner, and we'll have to make those our last 2.
Hi. Thank you so much for your words. I think all of us were extremely moved by your stories, and I'm certain that this will be something that we carry on for the rest of our lives. I actually did have a question, which was, if there was one skill or thing that you would tell your past self to develop to prepare yourselves better for your careers and to deliver better care to the community, what would that be?
These are all great questions. We should have had them in advance so people could think about them.
I'll tell you what I say to lots of students now, and what I think is really good, even for back then. Be curious. Be curious about people, be curious about yourself, be curious about the system, be curious about all of it. Just be curious, and that will help you ask the right questions and listen more. And I think when I was younger, I was really convinced I had all the answers. I'll tell you, the role I'm in now, I also now really know I don't have the answers, right? But I'm curious. I'm willing to ask those questions. And if you take that from the people in front of, from the folks that I'm serving on the street all the way to the people who are making the policies, and you just go with curiosity, you will find yourself in some really cool places.
Something I always talk about in my classes is the concept of humility. Recognizing that those with whom we're spending time with have a lot to teach us, and that we're the students in those spaces.
I would say not to judge, just to be recognize that the person in front of you, you could be in the other side sometimes, and you will just wanted to treat the other person as they treat you. humble and do not judge.
Last question over here.
Hi. My question is more catered towards street medicine, which is something I heard about today for the first time. And mainly, I guess I would ask, because of recent Medicaid cuts and rural hospital shutdowns for a lot of rural communities in, our country as a whole, do you see street medicine being projected to be something that is the primary use of healthcare for housed people in rural communities? And do you see it as something that could be magnified because of the recent Medicaid shutdowns? And how would the magnification impact street medicine as a whole in a good way and perhaps bring more light as an option?
That's a really great question, and I will say that street medicine is something that has a lot of bipartisan interest. So I think, homelessness, we know, was one of the top ballot measures that most people voted, and so along that line, I think that what we've been able to do over the last few years is identify street medicine as a real intervention that has really great outcomes. So I've housed 40% of my patients. So this is something, and that's not just me. That's street medicine is, health leads to housing and leads to sustained housing. I think that's one of the critical things that people don't realize. So in answer to your question, I think that we have a really good opportunity right now to continue to grow to meet the needs. Now I'll tell you this though, the need is already there. The number of us versus how many people need those services, we don't even come close, no matter where you're looking on the map. And so we would need to really, really see sustained levels of growth to meet those needs. Now, I'll tell you what my favorite thing about the street medicine community is, if you want to see a group of people rise to the challenge, go hang out with some street medicine folks, because that's where they do it. So I do see us as a possible intervention to help fill some of those needs, but not as it stands right now. Yeah, we would need to do some major growth.
I just want to add that for those who are, you're all young, but before, there used to be a lot of what they do, home visits. And used to be like the doctor goes house by house. And I think I just remember, when I was little, that the doctor will come where you are to the house. But now a lot of people are unhoused. And I think the doctors need to come out from the hospitals and clinics and be on the streets, because that's where the majority of people are.
I'm going to turn it back over to Suhani to wrap things up. And thank you all for coming and for dealing with the chilliness of this room.
So thank you again, Dr. Shortash, for acting as our MC for the afternoon. And we also wanted to give another thank you to our amazing panelists, the community, and UCSD especially for all the orgs that have participated today, our co-sponsors, and the Global Forum for co-hosting. This is obviously the extra credit QR code for the course credit. And there's also some printed pieces of paper in the back if you guys aren't able to scan this one. It's not working? It should be. Can someone raise their hand if they've been able to fill it out? Okay, I filled it out personally, so it should be working. Thank you. We're gonna leave it up for a couple of minutes, and at the end, we do also ask that you guys wait to fill out the Global Forum feedback survey. Again, we've been really grateful to be able to be hosted by iHouse and have this as a global forum, and we'd really appreciate any feedback for the co-sponsor organization. Thank you. We're just gonna have our panelists take a couple of pictures, and then if you guys have extra questions, you can find them while they are still here. But if they're going out the door, please let them leave.